Hi, Anne. Oh my gosh. I am so excited for today. Um, I did want to give you a very quick background on how a giving circle works, and specifically how Aurora's giving circle works. Um, those who like to become members begin by donating to the overall Giving Circle pool of funding, which, as I said, at the moment is over $27,000. At Aurora, there's no minimum donation, $25 or $2,500. Every one of you has the same voting power. And 100% of donations go to the 4 chosen community organizations. As of 2020, Aurora doesn't keep any portion because we want all of the funding to go out to where it's needed most in the community to support women and girls. So our steering committee helped identify this year's recipients as Mutual Aid of Hartford, the Diaper Bank, Reproductive Equity Now, and Planned Parenthood of Southern New England. During the next 3 meetings, members will learn about this crucial issue and about each organization that we're funding. At the final meeting, which will be in person on Wednesday, May 29th, the location to be determined, members work collaboratively and through a democratic process to grant levels of funding to each of the organizations. So all organizations you'll hear from receive a level of funding, but members vote on how much each of them will receive. It is always fascinating to see how that process unfolds, and ultimately everyone feels so positive about the outcome, but also realize that philanthropy is hard. It is extremely difficult to divide up money to such incredible community partners. And there's never enough to do everything. But when we work together, like we're doing today, it truly has such an impact and makes a huge difference for each of the organizations and ultimately for all women and girls. So, as I said, never fails. I always cheer up. But anyway, I will turn this over to our amazing leader, Dr. Jennifer Stedman.
Great. Well, welcome everyone. And I really need to shout out Marie for her amazing work, bringing everyone together for the Giving Circle. It really does highlight what is most amazing about Aurora and the community that we've built. So I'm so excited to have our returning Giving Circle members and all of our new folks here. So since we have so many new folks, I won't take long, but I do want to give a little overview about Aurora. So Aurora is Connecticut's only freestanding women's fund. Women's funds are important because their purpose is really to change the way that charity and philanthropy works. As you can see from this very depressing slide, charitable giving in the US totals about $486 billion. But of that, only 1.8% is directed to organizations that serve women and girls. That 1.8% number is just way too low, especially because we know that women and girls are such an amazing charitable investment. We know that every dollar we put into an organization that benefits women and girls will return, more than return that investment, as women share those resources with their families, with their communities, and really make the kind of change that we all want to see to help our communities be the best of what they can be and really thrive. So that's Aurora's main purpose for being, right? Is that we raise funds, we distribute them in the community, but also we're out there really spreading the word about why investing in women and girls is so important. We have several strategies that we follow, and since we have a number of meetings, I'll just do a meeting. So I wanted to talk about our grant making into the community, particularly our grant making that's focused on college success. So you can see here on the slide the amazing organizations that we partner with to fund programs that are truly innovative in how they help more low-income women of color and first-generation women college students navigate higher ed so that they can get their degrees and get jobs that pay a family-sustaining wage, right? So our research demonstrates that a woman's salary can double from having a GED to having a bachelor's degree in Greater Hartford. So we know that if we can get them this access to higher education, that they will thrive and change their families and communities. Next slide. And I just wanted, I couldn't not have pictures of the amazing students. When you support Aurora, these are the young women that you are supporting. And there can be young women, they can be moms that are returning to school. We've just this January released new data on student moms, right? So that a huge portion of particularly Black women students are moms who are returning to school. So how do we support them? How do we help them and their families get, get to economic security and economic mobility? So these are the faces of the young women whose lives that you change with these opportunities. And then finally, I just wanted to say something about a historic partnership and gift for Aurora. The Charlotte and High Good Family Fund supporting women's potential started partnering with Aurora for last year. They saw the work that we were doing with our college success programs that we fund, and we were able to create a whole additional program that takes those programs and really puts them to just another level. So Charlotte and her niece, Bobby Schmidt, wanted to make sure that the barriers were removed for women, particularly single moms, and their access to higher education. So this fund brought $1 million commitment, right? The largest in Aurora's history. And also an example of the way that as a women's fund, Aurora's goal is to, bring these kind of charitable dollars to our communities. So now 6 women are receiving not only access to these amazing supportive programs that we fund, but money for childcare, for housing, for transportation, for all of their basic needs, everything that made it hard for them to participate in higher ed. To say that it is magical and it is something that we are carefully documenting and hope that we can expand and that other places can replicate, that's the kind of work that your support of Aurora supports. So I hope you feel as good about it as we do. It's pretty amazing. So that's a background on just a little bit about some of the things that Aurora does. But what I am also super proud of is that we are able to bring truly amazing experts to talk about issues that are so important to women and girls. I am grateful to Donna Shadipo and the YWCA Hartford region for connecting me with Dr. Lucinda Canty. She is the perfect person to help us understand what reproductive equity means. She is Associate Professor of Nursing and Director of the SeedWorks Health Equity in Nursing Program at the University of Massachusetts Amherst. She earned a bachelor's degree in nursing from Columbia University, a master's degree from Yale, and a PhD from the University of Connecticut. Dr. Canty has provided reproductive health care for over 30 years. And what I think will be especially special about today is that she's going to share her lived experience as a Black woman. She's going to share a historical perspective as well as her poetry and art to help illuminate her research into racial disparities, to offer a reproductive justice lens to improve racial disparities in maternal health. She also founded Lucinda's House, a Black maternal health collective to promote maternal health equity through community collaboration and programs that provide support and education. Welcome, Dr. Canty.
Thank you. Thank you so much for having me. I love the work that you're doing and how it's so important to support women and girls, but also just to support women of color. So I'm going to share my slides and also just tell you a little bit more as I'm going through the slides about who I am and what I do. So, and as what was just said, next month I'll be celebrating 30 years as a midwife. So, and please keep in mind, I was probably about 5 years old when I started. So I don't want you to do the math too quick, but I've been around a long time in Connecticut. My work has branched out into Holyoke, and even currently now I'm doing some work in Springfield, but Connecticut is my home. And being a nurse midwife, I have seen like so many things. And before I get into my experiences, I do want to share like kind of where I'm at and what I'm doing now. And I do address maternal health equity in a lot of different lens. I still practice at Planned Parenthood. You know, I can't practice as many hours as I would like to, but I'm hoping to change that over the summer. But I just believe in their mission in providing reproductive health care. I'm a qualitative researcher. I love hearing statistics. I'm going to share a few statistics with you, but I really want to know who are the people behind the statistics. I have a Black feminist perspective. Any space that I'm in, I'm uplifting the voices of Black women because we're in a lot of spaces. When I think about research and healthcare, our voices aren't often heard, our stories aren't often told, and our stories and history have value and is a part of American history. So any space I'm in, I do like to uplift that. I believe in being in the community. I feel like I can't do things from an office. You know, I'm not to say that you can't do that, but my experience is that I have to see what's happening in the community. I don't go into any community without knowing what their needs are and how they want me to show up. And you'll see that history is important to me, but I also love storytelling. And that's just something that's passed down from generation to generation in African American communities. I should even just say Black communities. We tell our stories because there was a time we didn't have a space to capture them. And I love the arts. So you'll see my artwork throughout. And if I have some time, I like to share a poem as well when I finish. And I just want to go through just the statistics really quickly. I'm not going to spend a lot of time here because I know that we know we're in a maternal health crisis and really no one should be dying from during childbirth or a pregnancy related cause. But unfortunately is a reality in the United States. And when you look at how we compare to other countries, you see that the statistics are also very alarming. So you can see that. You see at the US and those numbers, we haven't had the most recent numbers yet. And I'm a little nervous to see those numbers. But even since like COVID started to really put highlight a lot of the issues that we're seeing in maternal health and healthcare in general, but the numbers still continue to rise. And so, you know, one of my things is trying to understand why. How do we get here? And when you look at racial disparities in maternal health, in reproductive health, because even though I'm going to really focus on maternal health, when you look overall in reproductive health, you'll still see areas where Black women or other women of color are disproportionately impacted. So we know maternal mortality, 3 to 4 times more likely to die. Severe maternal morbidity are those life-threatening complications, twice as likely. Infertility, perinatal loss, infant mortality, we're still seeing like at least twice as likely. And the reason why I say that it seems that way, because when we look at perinatal loss or infertility, there's still an underrepresentation of those numbers in communities of color, because that's something that we don't often talk about. So the rates may be higher than we actually believe. And even to find out that someone who has infertility treatment and they become pregnant, there's a high risk that that pregnancy is not even going to make it to where that baby can survive. So it's just really alarming. And that my question has always been, how do we get here and why? And I share this picture because when I first started looking into maternal mortality, I was told that we were poor, we were uneducated, that we started prenatal care late if we show up at all. We don't take care of ourselves. Even a colleague said we have a bunch of diseases. So that was the reason I was given why Black women were dying. But that didn't make sense to me because I had patients who lived below the poverty line. I had patients who showed up 7 months pregnant because they were afraid or they didn't have the resources or they just weren't ready and had to work some things out before they came in for care. But I provided care and they made it to delivery. So when I heard these things, and then all know of Serena Williams' story, how is someone who's the picture of health, the picture of financial security? I wish I had just a fraction of her money. I wish I had just a little piece of it. But it just shows us how there's something deeper happening in our society. And I want to know what it was. And when I first started looking at research, one part I found was that no one was talking to Black women. Everything was statistics. Everything was either hospital records, how insurances were built. And based on that, they tried to build why they believe Black women were dying. And there were studies that came out more recently that talked about how women were mistreated during childbirth. If you could imagine your most vulnerable, most intimate time, and you're being mistreated by those who are supposed to protect you and to provide you safe care. So when we really look at it, we start to see that women of color were more likely to have higher rates of mistreatment. And there's two stories. This is the Giving Voice to Women study, but also the CDC did their own study and found that women wanted help and they weren't given help, saying that they were in pain and not receiving treatment for their pain, being yelled at or scolded. And if they were offered a solution, that let's say someone's told, oh, you should just have a C-section, and they're like, I don't want to have a C-section if I can avoid it, or I don't want to be induced. They were more likely to experience their providers belittling them or devaluing what they believed in. And just feeling, again, can you imagine being in childbirth and just not feeling safe? And we all heard stories about pain. And there were two studies that looked at Black women, Black and Hispanic women postpartum. And what they found was that white women had more documented pain assessments. So someone was more likely to ask them, nursing was more likely to ask them about their pain. But Black women had higher rates of pain. They rated higher on their assessments, but they were less likely to be medicated. And then they were less likely to leave the hospital with their pain properly treated. So if you can imagine having a cesarean, having major surgery, and you're sent home with ibuprofen. And some of us know ibuprofen barely covers menstrual cramps. So can you imagine having major surgery? So again, I want to know, how did we get here? And how do we keep those who are in our care and our community safe when they go in to when they're pregnant and they go in to give birth? So what do we do? And so one thing I had to do was start to look at my history, especially because I'm like, how did we get, it wasn't always like this. When I first learned about midwifery, I was a senior and actually in my nursing program, I heard nothing about midwifery. And I saw a birth that happened right in front of me as a nursing student, and the woman who delivered the baby was a midwife. And I was like, I don't know what that is, but that's what I want to do. And I remember running home and telling my father, I want to be a midwife. When I finish school, I'm going to go back to school. And he's like, you don't know about midwives? He was like, how do you think we all got here? And my father was like, we were all delivered by midwives. He's from South Carolina. And he was like, that's how we all got here. We had he was like, your grandmother had us all at home. And my brother was like, on purpose? Because he was like, how do you, he didn't know of such a thing either. And my mom was from Georgia, and all of them except for her youngest brother and sister were born in the hospital. But midwifery was all that they knew, and not only as far as childbirth, but also how they took care of the community. So I'm like, my dad who was born in 1938, was saying these, he reflected back very positively. So I want to know more about Black midwifery, birth in the Black community. And what I found was that there was a different way that care was provided. Midwives were from the community. No one else wanted to go into the Black community and provide this type of care. So the midwives, they knew the context of the times, even since slavery. And midwives during that time, enslaved birthing people, was able to give them a moment where there was some safety, where they were empowered during the birthing process. They didn't know what was going to happen with this baby after, but at that moment, there was an environment that was created that was safe for them. And as you start to look at Black history, you'll see that there was a community around giving birth, around pregnancy, giving birth, and even postpartum. Midwives told me stories of how they, when a birth was happening, or they would notify people in the community. The local church would make sure that that family had what they needed. Somebody would come and cook. Someone would watch the children, even postpartum, because they knew that after giving birth, you had to rest and take care of yourself. So those are all pieces, again, that were important. And then in the Black community, there was, and it still continues to this day, we still celebrate birth. But I always wonder, like, when was that piece of where we had healthcare providers that provided care, understood social determinants of health, found resources, but also made sure that they were safe? I heard a story about a midwife who the actual descendant is 80 years old. And so this was her great aunt, Miss Sarah Penning. And she said how she was so respected in the community that, you know, people, if she needed something, there were people who were there for her. And she delivered everyone's baby in this community in Oklahoma. But she talked about how her aunt knew how to provide care where her brother delivered prematurely. And her aunt knew to use bricks to keep him warm and make sure that the baby didn't have a lot of visitors to prevent infection. So there was a science to the care provided. But when there was a shift from home births to hospital births, the community could not go to the hospital. Midwives couldn't go to the hospital. So where a woman was promised to be safer, being told it was safer to have your baby in the hospital, the reality was that they were going into a system that was separate and unequal. And that, again, think of these times where people didn't really want to care for anyone in the Black community. But when it became that it was a way to make money, it didn't mean that they want to really care and make sure they were safe. It was that they wanted to make their money. And when we're looking at maternal mortality, when we're looking at reproductive justice, it's really telling you how someone is valued in that environment, in that state, in that country. So these numbers tell us more. And so anyways, Black women went into a system that was not really made for them. And unfortunately, very little changes have happened recently. And I want to make sure that I talk to those who experienced those life-threatening complications. I want to know, I was like, they were the best people to tell me, you know, what was it like? What was it that you needed? What wasn't there? And I just wanted to hear their experiences, because my idea is really to get back to providing that care in the community. Not to say that every woman has to have her baby in the community. What I'm saying is wherever she is, the community is there with her. So she does have her baby in the hospital, she's not alone. And there's some connection where she knows that there is someone who's there advocating, making sure she's protected. And just really providers there that want to make sure that she has safe passage. And so the women that I interviewed 9 women, and some of them had 2 experiences of life-threatening conditions. So I had a total of 13 conditions altogether. And what I found, and I use a methodology for my research that allowed me to use art to represent the themes. So some of the things that I found out was about health education and just how information was sometimes withheld, or the information, when it was provided, helped them to make a better decision about going in for care. I learned about how that relationship with the healthcare provider was so important, that women wanted that relationship with their provider. But what they found, it went 2 ways. Either they felt part of someone's routine, somebody comes in, they do your weight, they do your blood pressure, they listen to the heartbeat, and then they're on to the next. No compassion in the care. Some women felt safe and well cared for because they had a provider that came in, that asked them how they were doing, that asked about the family, that asked about what was important to them. Even one of the participants said, my provider said, any problem is a big problem. So if you have a question, contact me. And as soon as she started to have symptoms, she contacted him right away. And when she came in, she said that, you know, because she came in quickly, she did end up being admitted to the ICU for preeclampsia. Her blood pressure was through the roof. But if she didn't have that space to contact her provider, she could have stayed home longer and could have experienced more severe complications. And it just brings me to the other parts of our care, is knowing that race had played a role in the resources that were provided and the type of care that was provided. Even patients telling me that, oh, they wanted to tell me about government programs, but they don't want to tell me about the complications. And I want to know about the complications so that I could prepare. So they knew that race had an impact on how they were treated, even feeling like when they did report symptoms, they weren't believed. If you can imagine someone 28 years old, even underweight before she became pregnant, gained the appropriate amount of weight. And after she delivered, she felt tired all the time. And she thought it was just being a new mom. And because she was breastfeeding all the time. But when she started to have chest pains, she went to the hospital and she was evaluated in the emergency department and was told, oh, you just have a little angina, just go home and rest. Another provider stopped her before she left. And what they found out was that she was actually in heart failure. So she felt, and they even told her that if her heart didn't improve in 3 months, she would need a heart transplant. So she says, if that provider didn't stop me, I wouldn't be talking to you right now. And I share that story because she said, when I looked back, I had all the symptoms that something was going on with my heart, but they didn't believe me. And because they were the provider, I trusted them. So it was just something very scary to think about. But because of these experiences they had, this picture where you see the three bodies is because there was uncertainty. They didn't know if they were going to survive. And even now today, when you have someone who's a person of color, especially Black women, and they're like, I don't even know if I want to get pregnant. So that uncertainty kind of still is on the opposite end, even before they're pregnant. So we really have to work towards changing that. But just realizing how pregnancy is so complex. And just from the study, just seeing that people like the information they received, the relationship with their provider, understanding race, uncertainty, but also mental health was another thing that women talked to me about, that no one assessed their mental health. And no one assessed it and no one supported it, even after they experienced their complication. And from my study, what I really learned that was very difficult a difficult pill to swallow was that race is not a risk factor. Racism is. Being Black doesn't mean you're going to die during childbirth, but your lived experience of what you experience day to day has an impact on your health. And being in that, and I can even just tell you as a Black woman, even when you go into a store, you could feel like all eyes are on you, not because they want to help you, but sometimes because they think that you're going to steal. Because when I ask for help, nobody can help me. But yeah, you're keeping your eyes on me and following me and seeing what I'm doing. So anyways, it's just when you have to deal with that every single day. It's like I wake up in the morning sometimes and I'm like, okay, what's going to happen today? I have a Black son who's 14 years old. He's 6'2". I worry about him just even going to high school. But when you just keep building that and you don't have a release of support of someone just to say, how are you? What can I do to support you or your work? It does weigh on us. People talk about the superwoman syndrome that Black women have. Unfortunately, we don't have a choice. We have to take care of ourselves. We have to take care of our families, and we have to deal with all the things that come with being racialized in this country. And so what is needed so that Black women can feel, or anyone who goes in for care, feel supported? And the most important is providing the health information that people need. And that includes resources. Because sometimes, and that's one of the things I find challenging with healthcare, is that we know not everyone is treated even equal. So two people walking in with the same conditions, one person saying she has a headache, oh, come in, we'll check your blood pressure. Someone else saying they have a headache, oh, just rest, you have an appointment in 2 days, we'll see you in 2 days. Both women end up having preeclampsia. One received care right away and one there was a delay. So we know not everyone is getting the health care that they need. So that's definitely something that we need to look at. We need to have healthcare that's culturally appropriate, that's done in a way that's sensitive to who you are and where you're coming from. We have to move beyond just the diagnosis. We have to move beyond the clinical skills of doing blood pressures and really learn who are these people in front of us and what is it in their lives that are bringing them to me today? And what can I offer them? So it just goes back to that relationship with the healthcare provider, but having non-judgmental support. It doesn't matter how you got here or how you showed up. You're going to get the best possible care that I can give you. And if I can't give it to you, I'm going to make sure you have the person who can do that for you. Or we're going to work together to make sure you have what you need. So it's important for healthcare providers to be aware of their own implicit bias and not just focus on the physical, but also think about the mental health and well-being. And I feel like everyone in the community, I have people who will come to me and say, my kids are grown. What can I do to help? Or somebody will say, I don't have any children, but I still want to help. I have nursing students who come and say, and I have to just give a shout out to Central Connecticut State University that came to me and said, we know maternal health is an issue. What can we do to make a change? And they helped me have one of the most, I want to say the biggest community baby showers that I ever had. And they didn't just come to say, you do everything and I show up. How can we even help plan? They were calling community partners. They did a diaper drive. They received other donations. They contacted community partners and said, we're doing this. Can you come and support? So it was that they want to go beyond just looking and then showing up and doing a little something and leaving. They really showed up and made sure the community was supported. But it's just recognizing that we can all do something. So it's very important for us to have community around maternal health.
I'm going to.
Can I jump in? Can you hear me?
Sure. Hi, Karen.
Hey, how are you? You're just amazing. Just like truly, first and foremost, out of the gate, your voice is so soothing. I could listen to you forever. And so my question is, you spoke a little bit about it, but are you seeing a change in the healthcare and from doctors, from OBGYNs who clearly, my daughter's an OB and she did a lot of research around this. She was on this call, but then she had to leave for work. But she's done a lot of research around the same topic. But I'm curious what you've experienced, as a midwife, the changes you've seen with doctors and the healthcare that women of color are receiving with this becoming more, the focus of, the data that you shared. And I would hope that there's some change. I mean, systemic racism is there, but we need to move the needle. And so the data is important, but it's what do we do next? How do we change this in a really profound way? So I guess I'm curious what your thoughts are about that and what you've seen.
Yes, and I love that question. And I will say that I'm seeing a change. And I'll give you an example. For example, Yale University reached out to me to talk to their residents to present my research. And I attended the OB GYN grand rounds because they do want to talk about this. And what I found is that people want to talk about it. OBs want to talk about it. And I also want to say that we got to look at nurses, people at the front desk, because we're all involved in this. And I think that sometimes when we're looking at these issues, people always want to say it's somebody else. It's not me, it's them, but they have to recognize we're all part of the system. As a nurse midwife, and this was something I had to reckon with myself, is that I came into the system not even realizing there were actions I was doing contributing to it. Having patients come, they had to be on time. You only have 15 minutes to see the patient. All these things, so it put me in the system. But what I'm finding with OBs, and not all of them, we still have a long way to go, but they are starting to look at themselves. But they're also realizing we were never taught to talk about this, but we need to talk about it even if we're uncomfortable. And when I did talk to the resident group, they want to see what can I do to improve the care. And sometimes they don't even know how racism shows up. So I said, if you walk in the room and you don't acknowledge the patient, you don't say hello, they got someone very important sitting next to them, and you don't address them. If they tell you something's going on and you ignore it and you say, no, this is what's really happening, without even giving them the space to speak, you're creating that environment. So after I finished, I had someone come up to me and say, I'm going to do better. When I go in the room, I'm going to start with asking, how are you? So something so simple, this person didn't realize how it can make the patient feel. So I feel like we're moving in the right direction. I did a talk yesterday. I had an optometrist say to me, what you're saying is right. Everybody's eyes look the same. She's like, everybody's eyes look the same inside. And it doesn't matter about race. But what she even acknowledged is how we approach the patient. And so I just like to say with your question that people are trying and they want to have these discussions. Okay, and Sylvan,
Great.
Thank
Yeah.
you so much for your thoughtful response. I really appreciate it. Thank you.
thank you. And am I pronouncing your name right?
Yvonne,
Savan? Okay, sorry, Savan.
thank you so much, Lucinda. Just really such important work. I'm in nonprofit work now, but I'm a physician by training and a pediatrician. So, the crossover to infant mortality and to which our country statistics are horrendous on as well. But I thought your point about understanding all of the levels in the system are really important, is really hugely important. It's like in everything we do, you can't just talk to the physicians because they're not the ones who are encountering patients all of the time. Can you share your thoughts about doulas and
Yes.
that potential importance and helping women advocate for themselves?
Yes, and I'm pro doula. I support doulas, especially doulas who are working within the community. They offer something that even I can't offer as a provider. Especially if they're coming from the community, they understand, like what I said about traditional midwives, they understand the context. They understand what's needed, so that to make the woman feel safe or the family feel safe in the care they receive. And they're educated in a way that they can advocate. They're asking questions. They're not coming in saying, I know better than the doctor. They're going in saying, this is what she would like. Can you just explain to her whether she can have it or she cannot? She's just looking for information. The only thing is I feel like we can't put the whole burden on the doula. We have to work as a team. Like when we're looking at policies, does a hospital allow the doula to go in? Imagine following someone for 9 months and now it's time for her to give birth and the hospital is saying, well, we can't have you because of your malpractice insurance. It's not enough. Or we can't have you because we have a lot of things happening on the unit right now. And if they do allow them, are they creating an environment where they even feel safe or they have a voice? Because how can they advocate for the patient if they can't advocate for themselves? So we just have to make sure they're supported. I also work with doulas that if they have a question that's medically related, I will say, I'll talk to her. And again, I don't go overstep and say, tell your doctor this is what you need to do. What I do is say, here's information and the pros and cons. So like when you go in for your visit, ask these questions. So we work as a team. And then if I have a provider that I said, this is going on with a patient, can you make sure that she's seen or that someone talks to her about this? It just creates that community. But also I feel too that we can't put the burden even on the mom, that we say, oh, go in and advocate. But in the community, if we know these challenges, we need to create an environment where nobody has to fight just to have their basic human needs met. But I'm very pro doula, and I think that we need to hear more from doulas to see how members of the community, but also the healthcare profession can support them.
I'm new to the state. Can you share what Connecticut's laws or policies or what you know about doula programs in Connecticut? And I
Yes.
don't know if everyone on the call knows what doulas
Oh,
are.
sure. I'm sorry. Let me even to break that down. So doulas are considered non-healthcare professionals. I still consider them an essential part of the team. They are educated in just anatomy and physiology, the process of labor. There's programs that will even teach about social determinants of health or how racism shows up. So they do go to a training. So in the state of Connecticut, and this has all been legislation that I've been a supporter of in the past 2 years. One is getting doulas recognized as a profession. So the state of Connecticut does recognize them. Now they're looking at certification and certification that's separate from their training, but certified in the state of Connecticut. And certification will help them with the next step that's going through right now is Medicaid is going to reimburse doulas for their work. So they're still working on that piece. And I believe it's going to be October. The date keeps changing, but in the fall, they're supposed to allow doulas to be reimbursed through Medicaid. right now, it looks like if they're certified, they can bill independently. If they're not certified, they can connect with the organization that Medicaid will reimburse, and that money should go, all of it should go to the doula. So that's where we're at right now in Connecticut. But the Connecticut is really creating an environment for doulas to feel supported. And there's a lot of local agencies that are providing funding so that doulas can be educated, so that's not a barrier for them, because there is a training program that could be a little expensive. And so there's programs that are supporting that. But Connecticut is really changing and supporting the way that we support doulas.
Thank you so much.
And if I may, do we have time, Marie, for another question? It's Renee.
Oh, sure.
All right, Dr. Canty, awesome, awesome. I've learned so much today. I am very appreciative. There are many times of your presentation. It really brought tears to my eyes, because as an African-American woman, I have experienced those exact things, including recently having to go to call my doctor to say I'm having this issue, and they tell me, oh, okay, why don't we do this? They gave me, called a prescription in. I did that. 2 weeks later, problem is back. Oh, let's do that again. But, you know, they finally called me and said, okay, this is what we think it is. Gave me a prescription again. That then a week later, same problem, different doctor, same practice, said, oh, my doctor's away. Why don't we try this? It's not showing up on the test, but maybe that's it. So they gave me another prescription for something else that they did not even have a diagnosis for.
Yeah.
I took it because now I'm desperate. What is going on? It worked. 2 days later, problem back. I go to my primary, since this one has handled it that way. They finally scheduled me a week later to come in. I go to the doctor. I'm feeling pretty good that my primary is going to see me. But a student came in and said, oh, I'm just going to take some questions. I ask you some questions. I answer the questions. And then she leaves, and the nurse comes in. The doctor never sees me.
Oh, no.
Then I'm very frustrated. I'm now high anxiety because I don't know what's going on. And I end up going to the emergency room and the emergency doctor there literally said, this is not what this facility is for. You should talk to your doctor. And I said, well, let me explain. I talked to my doctor. I went to my doctor. I went to another one of my private physicians or doctors. I said, and these are the things that's happened. I'm not leaving here until somebody examines me and tells me what is going on. You know, you want me to leave? You're going to have to call somebody to drag me out of here, because I'm not leaving. And it was only then that things started to happen, because I have a couple of friends who are physicians. And I said, I'm going to get on the phone with one of my friends who's a physician, and I'm going to ask them to come down here and facilitate my care, because you don't seem to want to give it. And that's when things started happening. And lo and behold, there was something, and I ended up having to have a biopsy done. The wonderful thing is, it was benign, not cancerous. But what if I didn't do that? What if I did? Why were there months of anxiety, you know, for me, when I followed every procedure that you told me to do. I did everything you told me to do, but yet and still, it never seemed relevant. And in fact, he told me this was not an emergency. And I said, it's an emergency for me. It might not be for you, but it is for me. And he said, in the end, at the ER, I'm glad you stayed. And he tried to send me away several times. And
Yeah.
it's unfortunate that we have to do that. Another time when I was years ago giving birth, my husband and I go to the hospital. He drops me off at the ER. I think my wife's in labor. They spent at least 20 minutes arguing that he was not my husband because I was not wearing a ring.
Yeah.
And I said, it doesn't matter whether I'm wearing a ring. It doesn't even matter whether he's my husband. I'm in labor. Why
Yes.
are we arguing about this? You know, it's just unfortunate that these things occur when they shouldn't be part of the story. It should be, you're in the medical field, you're here to help. That's
Mhm.
why I'm here, because I need help. What are
Yeah.
you going to do? And so I'm very glad that we do have people like you. I'm very glad that, you know, Aurora has brought you in to have these discussions and that we can share these stories. I've had my friends who are physicians tell me, you should write a book. You should write a book about these experiences, because no one would believe it. No one would believe that we
that's
have to go through this for something so minor.
exactly.
Something that's so, I'm not feeling well. What do I do? Oh, well, tell me the symptoms you're having. Just a
Yes,
conversation,
yes.
you
And
know, but no, well, it's just as you said, you know, take a ibuprofen, rest a few days. If it comes back, give me a call.
mhm.
I had one of my friends who is non-Black come to our daughter's graduation from high school, and she handed me a some sort of pill. I can't remember whatever it is, but it was something that calms your nerves. And she said, I had my doctor give me some extra for you. And I said, why would we need a pill? She said, oh, aren't you nervous? The anxiety. But you can get extra,
Mhm.
whereas I can get nothing. I
Yes.
don't need anything, but if I did need something, I can't get it. But you can tell your doctor, give me some for my friend. And they give it to
That's
you.
yeah,
These
and that
these are the
yeah.
things that
But that's it. Everything that you said with your experience covers what the issue is. And I just want to mention,
mhm,
when I do talk to providers, and I also feel that you should not have gone through that period. And just want everyone to know, a prescription should not be prescribed unless somebody assesses you. Somebody has to put their hand, and
yeah,
I see patients come in, nobody even touched them.
yeah,
I was listening to someone's heart and lungs, and somebody was like, nobody's ever done that for me. I'm like, if your insurance was billed for a physical, this should have been done. So just to highlight some, because there were so many things. One is that if there's something going on with you, and this is it, and the thing is that is what is important to you, not what is important to me when you come in for care. So if you come in, I had a patient come in, she was like, I think I have gangrene on my legs. And I know she didn't have gangrene because she would have walked in here, but I'm not going to say, oh, that's not gangrene, go home. I was like, I better check her legs, because if she has gangrene, I send her home. How is that going to look? But I still assessed her. I explained to her what was going on. I let her talk about what her symptoms were. And what it ended up being was that when she shaved, she got an infection in the cut. And so I was able to talk to her about how to prevent it from happening again. And she was just so happy over something. I don't want to say it's simple, but it was something that was important to her. But it was like we
right,
just talked about and the care was done. So when I do talk to healthcare
right,
providers, and I forgot to mention this when I went to talk to the residents and OBs, when somebody sees race, sometimes they don't even give you the standard of care. They don't do a history. This is what I was taught. You do a history, you do a physical, you do labs. And that's how you find out those things that could be benign or that could be more serious. But not to give, just to give a prescription. And I see people do that all the time. And they'll give you a prescription that covers everything in the world so that they're covered. So anyways, when you go in for care, you have a right to that care. If they don't give you the care that you deserve, if you should leave knowing something. Even if they can't help you, they should at least say, this is who you should see. As a midwife, I know my limits. I did all that I can do. You're still having abdominal pain. And this was someone who was a real patient. She still had abdominal pain. I refer her to I think it was a GI specialist. She had diverticulitis. But if I was just like, oh, you know, I did everything, everything's normal, you're fine. If you're still feeling pain, things are not fine. So, but sorry, and I know I'm running out of time. So I just want to say, but that's really the point is that when we go in for care, we need to leave with the care that we deserve. And the reason it's so important in your story, especially adding that somebody else got pills right away, that she could just she had enough that she could just give them to you. Probably was Valium. And that's a difficult.
That was what it was. That's exactly what it was. That's
and that's
exactly
a
what it
prescription you
was.
shouldn't be giving out lightly.
And I'm like, and you know what?
Yes.
And the poor, let me say this in her husband's defense. He looked at me when I looked at him like, is she serious? And he said, sorry.
Yeah. So we know, and I'll wrap up here, but we know health disparities show us that we know that some people are getting the care and some people are not. So it shows us that we can do better. So I found my poem. Can I read it really quick?
Sure.
It goes right to what Chef Renee just said. So the title of this poem is The Land We Call America. This land we call America. I sit in the complexities of life, wondering if I will ever feel safe as a Black woman on this land we call America. You call the land of the free, the home of the brave? Free, brave. I wish those words could mean the same thing to me and the sons and daughters I will birth on this land my ancestors built, this land called America. Built on the backs of Black and brown bodies, a forgotten history of birth, of pain, of suffering, but also of resilience and determination. It is because of Black women that I am here, still inflicted with 400 years of harm, still affecting the treatment of my womb. A Black body I'm still trying to control today in a healthcare system where I should feel safe, but we all know I may not survive. You act like you don't see me. You pretend that you don't hear me. You turn your head away from the treatment you know is killing me. Afraid to look in my eyes, afraid I'm going to tell you the truth. Look at me, listen to me. You need to know my history. Wait, excuse me. You need to know our collective history. You need to know who I am to understand why I fight, just to safely give birth on this land we call America. Thank you. Thank you for having me.
Thank you so, so much, Dr. Canty. Thank you all I think we had 40 people on the call at one point. So, you know, so glad that you could join us today. We'll be having 3 more meetings. Marie laid out at the beginning. So next Wednesday, join us to hear from 2 of the organizations that will be funding Planned Parenthood of New England. And I think the Diaper Bank, is that right, Marie, our next week?
I think next week is Reproductive Now.
Oh.
Yeah, Equity Now and Planned Parenthood. And then the following week is the Diaper Bank and Mutual Aid.
Yeah, and Mutual Aid of Hartford. And I'm excited for that one. We keep calling it Mutual Aid of Hartford, but they have a Black Mamas Giving Circle that provides doula care in the community. So we're excited to hear from them. I thought your poem was such a great way to end today's session. And then I think Marie has a couple of more save the dates on her slides.
I do.
Supposed to mention.
Doing the plug, we are thrilled to say that our Luminary celebration is going to be Wednesday, October 23rd at the Bushnell. If many of you came to the past few events that have been at the Yard Goats Stadium, we'll be moving inside, so weather will not be a factor. And it's a wonderful event, and that is a fundraiser for Aurora. So we really hope that you will join us for that. And if you're interested in hosting to fill a row with your guests, please contact me. This is a few of our fabulous attendees from last year, and we get to meet and mingle with the students of the programs as well. And then the other save the dates are June 15th. We have a 100 Men campaign that has started. Michelle Murphy is heading that up. And we're excited that the Women's Leadership Forum that's held at Connecticut State College Capitol is Thursday, November 21st. And again, that has students and they meet mentors of Aurora and professionals in the community. So we're very excited. And thank you all so much for joining us. Another, and 1 o'clock on the nose. Look at that. We're like, thank you so much. And we will be in touch. And as I said in the chat, we will be sending out a recording for you to share. And Dr. Canty, if I could have a copy of that poem, I would love to be able to share that as well. So you can just forward that to me. But thank you all so much and have a wonderful rest of the day.
Oh, and please be sure to let Marie know if you can come to the in-person lunch. Where
Thank
since we have so many, we're trying to figure out how big a place we need. And how much
Perfect.
room to get.
Thank you so much.
Bye-bye.